Hi everyone, Melissa Turner, the Tooth Girl here, coming to you on behalf of Spark Study Club. Now we have an exciting CE webinar coming up on July 16th at 8 p.m. Eastern with industry expert Dr. Brad McAllister. He'll be speaking on cellular bone allografts, clinical pearls for optimal regenerative outcomes. So you can go ahead and register at sparkstudyclub.com, and there will be more information and more webinars like this one coming down the line as well. Know that we have limited seats and then that you do earn CE credit for this webinar. So Dr. McAllister, thank you for being here this evening.
Yeah, it's my pleasure, Melissa. We're really excited about this webinar series.
And it's much needed, I'll tell you that much. So for those listening, we wanted to take a couple minutes today to give you an introduction. If you don't already know Dr. McAllister, we're going to dive in just a little bit about implants, about his focus, so that you can get a taste of what's upcoming, and then you can go ahead and register, obviously, for that. So the first thing is, Dr. McAllister, now I know I'm not going to read your bio, but I am going to read some of your certifications and licenses because I want everyone to know that you know your stuff. Okay, so here we go. So bear with me. Dr. McAllister owns a private practice in Oregon, right here with me. You earned your DDS from the University of Washington, PhD at the University of Texas, San Antonio, board certified diplomat of the American Board of Periodontology. Hang in there, we're almost done. International Congress of Oral Implantology. He's a fellow of the International Team for Implantology and the International Society of Periodontal Plastic Surgeons. So you know your stuff. You are the expert. You have the experience to back it up. And obviously, I'm excited to be with you. So let's talk about implants then. Why is this your focus? How did you end up in this as your niche in dentistry?
Well, that's a pretty long story, and we have only a few minutes. But when I trained, there was very little implant work being done. So I think I timed things quite nicely in that was sort of the beginning of Brandemark's era with training. And I was lucky enough to be at University of Washington and at San Antonio. Both of those were two of the four training grounds for Brandemark system implants. So that was kind of how I got into the whole implant arena. And then San Antonio has, just a history of phenomenal regenerative mentors there. So I was very fortunate to have people like David Cochran, Jim Melanig, Raleigh Meffert. These are people that influenced me greatly and kind of got me going down this whole regenerative pathway. And I've spent over 20 years studying different growth factors, different graft materials. We're now at a point where it's been very exciting to see the cellular bone allografts really take off in dentistry. While they've been used a lot in orthopedics, for a variety of reasons, they haven't seen as much use in dentistry. But now that they're being distributed in dentistry and there's particle size changes, packaging size changes, all of these things are making it much easier for dentists to utilize this material, which in my hands performs similar to autogenous bone without having the harvest issues. There's no side effects with autogenous bone. Normally we have a lot of complications and side effects, plus it takes a lot more time surgically. So to have the autogenous bone-like characteristics, but be able to get it essentially off the shelf has been a real game changer for us. So kind of an exciting sequence of events, and here we are.
Why do you think it has taken so long for this type of allograft to come into dentistry, for it to even, it hasn't even taken off yet, right? But like it's been introduced now. Why has it taken this long?
Well, there's two components to that. I mean, one of the biggest components is that dentists in general are laggers. We're very science-based and we want proof of concept. And sometimes that's very difficult to get the studies done to get that done. The other aspect of it is the FDA is involved in a lot of the different products that are sold. And so you have to go through a certain level of due diligence when it comes to FDA and that. So that's why I think a lot of this has been very slow to come, is both the regulatory side and then also the fact that penetrating into the dental market with a lot of laggers, just takes time. And I think the more data we compile, the more people see the great results and they get excited about it. The other thing is distribution in the dental market is a little bit more tricky than in medicine. In medicine, if you're having an orthopedic surgery, you're looking at a surgery that's, probably between hospital stays and surgeon costs and all of that, you're in at 10,000 plus, whereas most of our little regenerative procedures are under 5,000. So the cost of your bone graft material does impact things. So I think people are cost conscientious in dentistry. And so having a distributor now in dentistry and having product sizes that are working nicely for our smaller defects has made a big difference, I think, in terms of penetration and enthusiasm within the dental market.
I know the US, as far as regulatory, is often takes its time with these kinds of products, and other countries will often, be utilizing this sometimes for decades before we get approval here. Are there other countries that have been using this like that for a while, and it's a proven, it's just a norm for them?
Well, there are other countries that are involved with cellular bone allografts, but I will tell you, we're probably the leaders in cellular bone allografts. There are other products, like you say, that are approved. For example, FGF is approved in Japan and not in the US. So, we see different products being approved in different jurisdictions. But at least with the cellular bone allografts, I would say the US is probably leading the way, and that's always exciting.
Oh, that's very good. That's where I thrive. I love that. That's where the dentists in the US can lead the way, can be the innovators for that. Okay, so then I want to kind of broaden it just a little bit. What do you think is the biggest concern right now for dentists who are placing implants in the US? What just overall, what is the biggest concern? Would it be the bone grafting, or what would you say?
Well, I think the biggest concern is peri-implantitis, and this is a little off topic. I wasn't expecting to talk about it, but that's truly the answer that I would give you. And the best way to avoid peri-implantitis is through your hygiene program, maintenance, and having the patient take care of the implants, which obviously is not the topic of our talk here. I will say the other aspect that makes a big difference is having proper bone volume for your implants. It's pretty easy to get an implant to integrate, but having an implant integrate and have adequate bone surrounding it to help prevent peri-implantitis and have an aesthetic outcome, that's a different story. So that's where I think having excellent bone graft materials and good soft tissue grafting techniques can be a big step forward to minimizing peri-implantitis. So obviously the maintenance side is critical, but then also your site preparation is critical.
Mhm. I like that you introduced the periodontitis as a hygienist. That's our focus all day long. We live and breathe it. Unfortunately, we live and breathe it, right? And I do know there's some oral testing and some things coming down the line that will help test for that and maybe even help diagnose it. So that is exciting news on that front. And hopefully then in the future, then that doesn't have to be a concern for implants. Now, when you're in your own practice, when you're speaking with the patient about this type of graft, how much information do you give them? I know that's a question. Do you give them all of the information? Do you let them choose what graft they have? Do you even tell them, what information do you convey to the patient in this situation?
Well, I think with modern day consenting, it's critical to give them as much detail as possible. I will say it's very different patient to patient. If I have somebody that maybe is elderly and has limited capacity for understanding, I maybe keep it a little simpler. But then I'll have somebody that comes in that's a younger engineer that's extremely eager to learn and wants to know everything, and we dive into it much more than I would maybe for the average patient. So, I try to be specific to what the patient's needs are. I have some patients that just ask me, well, what would you use? And then I tell them, they say, well, that's what I'd like to use. That's great when the patients are trusting in, our ability after years of training to be able to give them what we think would be best. So I base it on patient to patient. With the cellular bone allografts, I do give them that as a choice, and I'm very specific with it because it is an added cost. The cellular bone allografts are more expensive than their traditional allografts. It's less expensive than autogenous bone. I still do use autogenous bone in my practice. But when we're going to a second surgical site, say I'm going to the symphysis for a block graft, that's actually going to cost the patient more. And the cellular bone allograft is probably similar performance, but lower cost. But both of those are a greater cost than traditional allografts or xenografts.
Mhm. So when you're looking at a patient, what are the parameters where you say this is a perfect patient for the cellular bone allograft?
So usually it's our complex defects. I like to use it probably for my more difficult, say 10% to 20% of my cases. Those are the ones that I'll suggest it. And out of that, some of the patients are motivated by cost. And so when I bring up something that I consider optional, I can tell them I can still probably get a good result, but it's not as predictable and may take longer for healing. Those that are cost conscientious may opt for the lower cost product and just wait longer and be a little bit more conservative in our expectations. So I think that that's probably a critical component to it. Periimplantitis is a great indication for it. Those are tough defects. So if we surgically have to manage it, that's a good example because those are difficult. And that's where oftentimes I will propose using cellular bone allografts. Obviously, any ridge defect that's significant, sinuses where it's just an eggshell, very little host bone would be an example. I also use it in advanced periodontal disease situations. Usually that's going to be where it's multiple defects and larger defects. We'll go to the cellular bone allografts for that as well.
And you use it in these situations because why? Because it decreases the amount of time it takes, because it's more effective. Why would you choose these situations?
Well, there are studies that show that we get a higher percent bone volume. These are histologic human studies. So if you're doing a sinus lift and all you have is a eggshell sinus, basically the implant's going to be entirely in bone that you regenerate. So you'd want that regenerated bone to have the highest quality of bone. So we're going to get a higher percent bone and it's more rapid. We see in about 3 months really good bone formation, whereas traditional allografts and xenografts are more going to be in the 4 to 6 month time frame. So if the patient is in a hurry, certainly only waiting 3 to 4 months is nice for them rather than maybe waiting the full 6 months that we oftentimes have to in these more complex defects when we're using other materials. So I think having a higher quality of bone, having a faster regenerative outcome can be important. When we look at periodontal defects, the regenerative response has been much more favorable in terms of millimeters. So, anytime we want to get a better outcome in a complex defect, we're going to go to products like the cellular bone allografts or growth factors to give it a little more zip than we would with just our traditional classic bone grafting materials.
Mhm. I think this comes at such a critical time in dentistry in specific. I remember, just like you, I started 20 years ago. And so that was right when implants were becoming more mainstream in the general dentist office, plus obviously in the specialist office. But uh, what I've found is that, especially with a new technology like this, or a new to dentistry technology, what I've found is often, we've got the dentists and the clinicians who are just comfortable, not doing implants at all. Then we've got the ones who are comfortable still using the materials that they were taught with, whether in dental school or in specialty certificates. And then we've got the innovators that are grabbing anything and anything new. So, but the bell curve, I would imagine, are the dentists who are like, okay, like let's let that group try it for a while, and then maybe I'll implement it in a year or two, right? So, what would you say to the bell curve, the mainstream dentist who is like, okay, I don't need to be like first to market with this, and I don't want to be last. What would you say would be a good process for them to begin to implement this into their pathways?
Well, I think a good starting point is to attend these webinars that we have. It's going to be a series, and the idea is we've got experts, we've got some really good clinicians. We've got Dr. Bob Miller, Dr. Thomas Ashragi, Dr. Mark Hartman, Dr. Kenyon, Dr. Gail Childers, Dr. Edgar Elchar. All of these folks are going to be participating in these different ones, either by case presentations or lectures. And it's going to be really clinically driven as opposed to research driven and histologic slides and kind of boring people. We're going to really try to dive into the clinical, how you make this work to the best of your ability. And so I think when people see lots of different clinicians having some outstanding results, it can get them excited. And then our goal is to make sure that they take away the pearls of how to use this bone graft material effectively. It is a little different. It comes in a -80 freezer if you have a freezer, or it comes on dry ice. So ordering is different. How you prepare it and thaw it is different. Having an understanding of what works, what doesn't, I think is real critical. So I'd say this webinar series is a great opportunity for them to learn. We're going to try to make it interactive. People can put up cases, and that allows us to maybe give advice or thoughts on it. And so that would be probably my first recommendation for somebody wanting to get involved with cellular bone allografts is to attend these webinars and get some good information, and that helps them decide what cases are good starting points. I always tell people rather than use your best bone graft material for the first time on your hardest case, I say pick a middle of the road case that is fairly predictable for you surgically, and then you see how well the material performs, and that gives you good guidance for future trying a little harder. Sometimes what I've found is that people will try whether it be new growth factors or cellular bone allografts, they'll try it on kind of their Hail Mary case, and then it doesn't work. And it's really not a fair representation of the product. It may be that the procedure that they're trying within their skill set is very difficult for that person. We all, as we say, need to know our limits, and we've all learned them. I've done cases that I pushed the limit and then they didn't work out so well. And that's one of the things we're going to try to share in the webinar series is complications and what's a reasonable expectation. So that way we don't have people trying things that maybe are unreasonable for cellular bone allografts. We certainly think that they perform quite well and superior to our classic bone graft materials, but obviously in biology there are limits to what we can accomplish. And I think the webinar series is a great way to kind of show through cases what is reasonable to expect and how to obtain those results.
So the key is when implementing this, start small. Don't do a Hail Mary case right away. Be comfortable with the patient first before you start this. I think that's key advice right there. I just want to, before we close, I just want to end a little bit more with the learning curve for this. So like you said, you have to have the freezer. Like what other aspects of the learning curve should the dentist be aware of going into this?
So I think part of it is the staff. The staff has to be aware of how you order and understand the thawing process so that they're comfortable with it. A lot of times, I know in my office, I have a great team. I'm very fortunate, but I know they like simplicity. So, if it's something that makes their lives more difficult, you have to work with them to implement that. So I think, part of that curve is having your staff on board so that it goes smoothly from the ordering process to receiving, then through surgery, having everything that you need to get the best outcomes with that. I think that that's a big part of it. And then obviously having gotten some exposure, this webinar series is an example, but you can read the literature. There's several great articles that can give examples of how this product was utilized. And so if you're coming into it educated, your cases are going to be much better than if you're using the material and you're doing the exact same things you might do with another material. Obviously, each material has its little nuances, and that's one of the things we're trying to do with this webinar series is make sure that folks really understand how to get their best outcomes with these little pearls, these clinical pearls that will help them avoid some of the learning curves that we've had as a group.
Yeah. As far as getting the team engagement on it, quite often I think, if there's a course that's dedicated to dentists, oftentimes it's rare to see the assistant or the other team members or even the hygienist there as well. But I think it's super valuable, even for this initial course about this type of regenerative allograft. Even the team members can come to this webinar. They should be fully educated in it as well, even though they might not understand everything that's being said or the processes. But it's super valuable to get that team engagement so that when the patient is in my chair, I can say, okay, Dr. McAllister, like, here we go. Like this, it's time. Let's do this. And so it's all about that education. So team members are welcome at this webinar as well, so we can get the entire team engaged, the entire team on board. Final question before we wrap. You mentioned longevity. Does this last longer than the traditional ways of bone grafting? And if so, what do we need to look for once it gets into that later stages?
So longevity is a difficult one because we don't have good long-term studies with many of our bone graft materials. I think what I have found is that we get great longevity because we've been able to regenerate good quality volume of bone. As I mentioned before with the peri-implantitis, one of the challenges is long-term, if you don't have a good bone volume and you put your implant in, they're more likely to get peri-implantitis. We oftentimes see this with facial defects. If you've got a dehiscence on your implant from day one, that's much more likely to have peri-implantitis problems than if you have a very good volume of bone, 2 millimeters plus of buccal bone. That's going to be much less likely to have peri-implantitis. So that's where I think these materials should give us the good longevity.
Mhm. That sounds great. And I know it's always hard. You can't predict the future. So we know that that's why that first patient has to be a comfortable patient for them. Okay, so we're gonna wrap. Dr. McAllister, where can listeners find out more about you if they want to contact you ahead of time to learn more?
Well, our website is www.portlandimplantdentistry.com. It's got a email. The other possibility is the Salvin reps. They're excellent reps, and I know that they're going to be out in the community promoting to their dentists this webinar series. They're the ones that actually distribute the product that is primarily in use right now in dentistry. So I think that they're going to be a great asset for folks as well.
Mhm. Well, Dr. McAllister, thank you for being here. Thank you for paving the way in this innovation and clinical innovation. Thank you to everyone who was listening. Don't forget to go ahead and register for the July 16th course at sparkstudyclub.com, and we'll see you then.
Thanks, Melissa.